Hello, welcome to another broadcast from Hepatitis Scotland. My name's Leon Wylie, I'm lead officer with the organisation. Today we're talking with Dr. Peter Rice, who's an honorary consultant in NHS Tayside, and he's also chairperson of SHAP, which is the Scottish Health Action on Alcohol Problems. And so today we're going to have a discussion about alcohol and with its relation to hepatitis, but a larger look at alcohol use in Scotland as well. One of the key things is we're going to talk with Peter's got a lot of experience in the area, so try and use the experience that he's had to kind of give hints and clues to how people can use that when they're working with people or people who are affected by hepatitis themselves, little tips they can take. And so, was it Carl Rogers, every intervention is potentially therapeutic?
Yeah, thanks Leon, and thanks for asking me to come along. It's an interesting task, a very important area to be working on with the work you do in hepatitis, which I think has been good work done in Scotland. I'm very pleased to be able to maybe help that along a little bit. As you said, Leon, every intervention has its potential therapeutic effect, and it's always worth doing. With the alcohol brief intervention programme in Scotland, we've I think been really pleased at how well that's gone. Most of them are done in primary health care, and I think the general practitioners, practice nurses and other primary care staff who are doing that, I found that's gone smoothly. Some of the preparatory work we did for that found that an expectation amongst those staff, people will be offended, they see it a relevant question.
Difficult conversation kind of stuff.
But in fact, the research work that had been done with the patients, with the clients, was that they expected to be asked about their drinking. They know that alcohol is relevant to their health, they know smoking is relevant to health, and they expect health workers and people in associated fields to raise that question with them. So in fact the resistance or the hesitancy of that came from the staff side. And once we get into running training programmes for staff in primary health care, the staff got over that, and the programme's really gone very smoothly, and in fact the numbers have been greater than we thought that they would be, and it seems there's probably about 100,000 brief interventions being delivered every year in Scotland, mostly in general practice, but in other settings like sexual health clinics and community facilities, accident emergency departments, maternity clinics. And we haven't had people getting up, storming out of the consulting room getting angry about it. So people expect these issues to be raised with them. They know they're relevant to their health, and I would encourage staff to raise that with people. And if people themselves are worried about their drinking, to use their GP and whatever other supports they have in the community to ask them and raise that with them.
If you have viral hepatitis, even 1 or 2 drinks can make a difference. Any kind of tips that you can give to workers or people about that?
Sure. Yeah, I think so much of work in substance misuse or addictive behaviours, whatever term you want to use, is to do with helping people understand their competing thinking. So very often people will know that what they're doing in terms of alcohol or drug use is harmful, but they're also kind of pulled into that. So there's a kind of seesaw, two sides of the balance thing going on. I know I shouldn't be doing this, but I feel I need to, or I feel I know there are downsides to this, but I enjoy it very much and I don't want to give it up. So that ambivalence is a very important thing to understand when you're working with individuals. And I think the way that brief interventions, for instance, can work is sometimes just by tipping that balance. And sometimes by leading people just to challenge some of the beliefs that they've held themselves about their substance use. Very common one we come across in the alcohol field is people believing that alcohol makes them sociable, and if they didn't have alcohol in their lives, they'd become very socially isolated. Yet often when you take people through, where they've got to now with their drinking at home by themselves. Family have bailed out. They're not seeing their kids. They're not in employment. In fact, they're leading a very isolated life. And you'll still have that person coming going, "But if I stop drinking, I'll have no friends."
Yeah.
So just the process of trying to get that person to stand back and look at their situation objectively, to take off the rose-tinted glasses that they have. And sometimes that doesn't take very much to do. The right thing said by the right person at the right time can have make an enormous difference. And I would always encourage workers just to do that.
Mm-hmm.
There's no great benefit probably in nagging and, you know, setting up a big conflicted situation with someone, but just, if you like, dropping the stone in the water. Mm-hmm. and seeing whether the ripples get to, whether they tip the balance for the individual is well worth doing, and you never know what's going to, as I say, help to tip that balance and make that change with people. Mm-hmm. It's easy for those of us working in the kind of treatment business to take for granted what's quite a privileged and special position that we have. We're in a different position from family members. Family members are often, you know, very involved in what's going on. They're often frustrated, hurt, upset at substance use that's going on. And it can actually be hard for them to have a kind of neutral, informative, objective conversation with someone, because they're kind of past that point. And the person who's drinking themselves are kind of, they're expecting that any discussion about the substance use within their family and friends is going to be loaded by what's happened before. Whereas staff workers have a more objective position, and that can often free up the person themselves to stand back and think about themselves in a more objective way. So it's different from sometimes these kind of very dug-in communications that people have got into with their families.
So, what's in the water in Dundee? You and John Dillon?
Well, I think John and I worked together for a long time, probably longer than either of us would like to remember, and it's always been a thing I've enjoyed about my work, is joint working with other fields of medicine and with other agencies. It's one of the great things about this field. So so we saw the world the same kind of way right from the start, really drawing on a body of evidence that's been around for a long time. So in a way, the kind of Scottish approach to alcohol, you could argue, has been nothing very new. It's simply been taking knowledge that's been around for, you know, sometimes 20, 30 years, but hadn't been put into practice. Alcohol brief interventions is an example of that. There's actually some very early work done in Dundee before either John Dillon or I were there by Nick Heather. The first, I think, randomised controlled trial of brief interventions was in Dundee in the early 80s. And so that's, you know, going back, 30 years now. But in fact, Scotland, maybe 4 years ago, was the first country to set up a national brief intervention programme, having known for 25 years that this worked. Similarly, with the action on alcohol price, that's been known for a very long time, but relatively few people had been, you know, brave enough to go forward and work on it. So I think that was the thing about the Scottish approach, was that actually was well versed in what we knew was likely to work. It was a case of pulling those things together into a coherent plan, really. That question about which particular kind of intervention is going to help which particular individual is one that the professionals have really been shown not to be as good at as we like to think we are. So the questions of whether someone's going to benefit from individual cognitive behaviour therapy, whether they're going to benefit from going to a group, whether they're going to benefit from going to Alcoholics Anonymous, whether they're going to benefit from any of the medications we have, there aren't clear-cut predictors of that. And I think the best approach is for the clients and patients themselves to identify what suits them. So there's an important role there to let people know what the options are, and then people say, I like the sound of that, I think I'll give that a go. But to review that if it's not worked out. So it's not a case where somebody can walk in the door and you can have a few questionnaires and say, okay, well, you're going to be perfect for this. And that's actually true of an awful lot of medical practice, that when things are going well, you're working alongside your patient, doctor, patient, nurse and patient are working together, helping to find an approach that helps, that works for them.
Do you think we need to work across addictions more?
The divide between alcohol and other drugs has become much less in terms of the epidemiology of use over the last 25 years in Scotland. So, but I think the important thing about services is that they're tuning into the needs of the people who are coming to them. And of course that people should not fall between stools. If there's a kind of smoking cessation service here and there's an alcohol service there and a drug service there, in my experience mostly people are able to choose which suits them best. They're able to identify, well, this is my main priority just now. But I think that services should be able to also work at the margins, including with tobacco. Tobacco is a very serious health problem for many people who are coming to hepatitis services, who are coming to alcohol services, who come to drug services. Some estimates are that the harm caused by tobacco and the mortality that comes from tobacco will be greater than any of the other substances that are around, or any of the other risks that are around for those groups. The populations who are in those services are amongst the groups who are still smoking at substantial levels, and I think that's something we need to do more about than we've been doing up till now. I mean, the academic research has been pretty consistent on this actually, is that if you're talking about, say, smoking and substance use, let's talk about alcohol, it's actually easier for people if they quit both together, because each behaviour tends to link to the other. So if people are drinking, that's when they tend to smoke more. So actually quitting both together makes sense, and the outcomes are better. But you have many conversations with people who say, one thing at a time, doc. And you have to respect that and work with it. I think you do need to say to people, and I have done, this might be easier than you think if you do both together. It might be easier for you in the long run. And some people will pick up on that and take it and do it that way. But for many people, they will take the one thing at a time approach. I think for tobacco we have an increasing range of interventions with nicotine replacement, including e-cigarettes. There's a lot of debate about that, but they may be part of the solution here. And I think we have to be, more active on that here.
We were talking beforehand about some of these stats. What's the concurrence between liver damage and alcohol currently?
I mean, alcohol in Scotland is a drug that we're very used to, that's been around for a long time. But there's a lot of harm comes from that across populations. That's one of the messages that we've been taking out over the last 8-9 years. And that's true of people who've been in treatment for hepatitis. And in fact, when work has been done to look at the long-term health of people who've been through hepatitis treatment, actually alcohol is the thing that really sticks out as a thing that can harm their health. So there's some work done in Scotland showing that probably between a third and a half of all long-term liver disease in people who've been through hepatitis treatment is in fact related to alcohol, not to the virus. So, and that I think is a really important message for people to get their heads around. Alcohol is very familiar. It can be easy to underestimate the risks and harm that come from that, but it's a substantial cause of mortality. Estimates that probably about a quarter of all deaths of men under 35 in Scotland are alcohol related. So the numbers are substantial, and so it's important for people who, if you like, have been through hepatitis treatment with all of that involves, the commitment that involves, to actually not come out of that frying pan into the fire of heavy drinking. So they really need to pay attention to that side of their health, because I think we've got good evidence from Scotland that alcohol can be pretty harmful for that group and lead to serious long-term health consequences, particularly for liver disease.
We'll probably get Peter to explain what CHAP is. So, CHAP.
Yeah. Yes, Scottish Health Action Alcohol Problems was formed in 2006, really at a time when we were seeing rising rates of harm from alcohol in Scotland that had risen really quite rapidly over the previous decade or so. And we felt there was a need for a medical voice to add in to the other organisations that were working in the alcohol field. Much of the harm that we were seeing from alcohol was very directly impacting on medical work, hospitals or clinics, and we felt that there was a need firstly to raise awareness amongst doctors, amongst the profession, and secondly for the medical profession to be part of the group of people who were going out and explaining to the general public and also to government really why things needed to change.
Because one of the key things was your work with politicians.
Yes, it was very important for us to have good data on this, and that's been a real strength in Scotland, that we have good data systems. One of the things we had to do was to make sure that the data that was collected was analysed and used and presented in an intelligible way, both for the general public and for political audiences. So there's a lot of work done on that, and that really paid off to be able to explain to people just the kind of problems we were facing. One of the issues in the alcohol field is that we're terribly familiar with alcohol, just because of our history and the way it fits into our society and our communities. And people tend to think that alcohol is there as a fixed thing. We know where we are with alcohol, been dealing with it a long time, we know where we stand. And in fact, things were changing, and that was a very important message to get over, that this wasn't just the same old, things were different. And that was, I think, a very important bit of our message, because sometimes alcohol's familiarity can lead to people underestimating the harms or adapting to the harms or getting used to them and really not paying as much attention as they should. So I think being able to have the data to show that as far as our hospital impacts, the number of people dying, needless young deaths from alcohol was rising, that was a very important part of our message.
We may have crested over the wave with liver disease, but why do you think, what are the factors that help make that happen?
Well, yes, we've had, I think, a very interesting situation in Scotland over the last 20 years or so with alcohol harming, including liver disease, where we had a very rapid rise, really from the mid-1990s onwards. And over a 10-year period, which is quite short in health terms, we saw rates of liver disease deaths doubling in Scotland. At least some figures suggest even more than that. So this was popping up in all kinds of places, in our hospital wards, in our mortality statistics, and with other measures of harm. And that was round about the time when CHAP was formed, because we thought we really needed to draw attention to this. There's been a very welcome decline since the kind of mid-2000s, and we're now seeing our hospitalisation rates are down about 30% for alcohol-related illnesses than they were. I think that whole 20-year cycle of a rise and then a fall has supported our argument that the affordability of alcohol is absolutely crucial in all of this. The time when alcohol was rising was a time really when we were seeing, to cut a long story short, we're seeing a lot of supermarket price wars on alcohol, using cheap alcohol deals to get people into the stores and to create a customer base. And I saw that in my clinic, that the pub drinkers that you used to get were just disappearing, and the price gap between drinking a pub and drinking at home became so wide. The more and more people were drinking heavily at home, missing actually some of the advantages that come from drinking in a pub setting. Of you're kind of in a community, you have some friends who might look after you if things are starting to get tough and might point you in the right direction. We were losing all of that, and really we became a nation of home drinkers. So we moved from about 50-50 home drinking, pub drinking in the early 90s to 2/3 of our drinking being at home over about that 10-year period. And that was driven by price. And that was why we were so keen on minimum unit price and still are, because it really tackles the very cheapest drinks that the heaviest drinkers end up drinking. So the cheap supermarket vodkas, the cheap ciders, the multi-buy beer packs. And I think what started off as a bit of a hunch that was the right thing to do, I think has since been backed up by really quite a lot of science. The interesting thing I think we've seen over the last, I guess maybe 6-7 years now, is that actually those affordability changes of alcohol getting cheaper and cheaper has reversed, almost certainly because of the recession. So people's incomes have fallen, and we've not seen the cheap deals, particularly in the supermarkets, that we used to see. So in fact, putting those two things together, I think that's been the likeliest explanation for these very welcome falls in hospitalisations and the number of people dying.
Okay, thanks, Peter. That was really some really interesting discussion that we've had in that, and thank you very much for coming along. And I hope you out there have learned some things from today. I've certainly learned a lot from this. And thank you and goodbye until the next broadcast. So thank you.
Okay, pleasure.
Bye.